Hello, class, and happy Sunday. Welcome to week 6 of Abnormal Psychology. I know last week I had a couple of mic errors. It might have been too low, so I'm trying my best to talk really loud today. So if I am talking loud, I do apologize. But I want you guys to hear me. So let's jump right into it. So for this week, you have a lot of reading to do. So you'll read chapters 11, which is over mood disorders and suicide, and chapter 12, which is over substance disorders and addictive disorders. So let's jump right into it. Also, I do want to mention that there is another vignette. This one is definitely an interesting one, and I think it ties into the discussion board post. So I'm interested to see what you guys are thinking and your thought process on that. So that should be a great introduction to introducing diagnosing and things like that. Also, you got the ones that did the vignette the first time. I believe you did a good job, so I think you should keep that up. And then of course you'll have your exam, and it is of course 100 points and it's 40 questions. And you guys did very well on that one last time, so I have more than enough confidence that you'll do great on that as well. So let's jump right into the lecture material. I don't want to, like I said, I don't want to spend too much time, but there's a few things that I want to touch on. Whoa, this is not it. There's a few things that I want to touch on for your chapter 11 and your chapter 12. Sorry, that should have been open, but I guess it wasn't. So let's start with chapter 11. So of course, chapter 11 is mood disorders, and you guys definitely know what mood disorders are. A lot of you have probably heard about bipolar disorder, major depressive disorder, and things like that. So we will touch on those, and of course suicide, and that's considered along with depressive disorder and mood disorders because it is contributed to someone's mood. So let's jump right in. So the first area of topic of discussion, of course, is depressive and bipolar disorder. So if you want a little more information on that after reading your textbook, feel free to hop on over to Crash Course videos. They have great information in a short amount of time, so you're not wasting a lot of time watching videos. And it has some information, so if you wanted a little bit more about that. So of course, the major premise of mood disorders is the disturbance of someone's mood, which is very disabling and is debilitating. So when you see mood disorders, you see two areas of discussion. You have your depressive state, and you have a manic state in some cases. So your depressive state is your melancholy type of, I can't get out of bed, I don't want to eat, I'm crying all the time, I have a loss of energy to go out and hang out with friends and family, things like that. And mood disorders are quite a common diagnosis within the DSM. So yeah, and then of course we'll talk a little bit more about manic. But the three levels of mood episodes are your major depressive episode, and that's when I talked about how you're severely depressed, you can't get out of bed, you don't want to eat, you don't want to spend time with your friends and family. You have your manic episode, which is the complete opposite. There's an elevated mood. You're extremely happy. You feel like you can do anything. You're on top of the world. So it's kind of that grandiose feelings of invincibility, I would say. And then you have your hypomanic, which is a little bit in between your major depressive and your manic episode. So you have those feelings of, grandiosity where you feel like you can do anything. You can go skydiving, you can do anything you would like, but you also have those times where you have a little bit of where the depression seeps in and things like that. So of course, there's few criteria in terms of mood disorder. More males are diagnosed with disruptive mood regulation disorder, and of course only women are diagnosed with premenstrual dysphoric. I won't talk a little bit about that, but of course there'll be more information in your text. So in terms of your depressive and bipolar disorders, there's quite a few that the DSM discusses. Of course, there's your major depressive, there's your persistent depressive disorder, there is your premenstrual dysphoric disorder, your disruptive mood disorder, which is most likely only diagnosed in children, and we'll talk a little bit more about that because major depressive disorder is not diagnosed within children. It's only for adults. So keep that in mind. You have your bipolar disorder 1, and you'll have bipolar 2 disorder, and you'll have your cyclothymic disorder. So those are a list of the depressive and bipolar disorders when we talk about mood specifically. So the most common, of course, is your major depressive disorder, and which is considered depression and things like that. So, and like I said before, it's only in among adults. And it can be incongruent with your anxiety disorders. It can be due to a substance use problem. It could be due to eating disorders and personality disorders. So, and also you have your persistent depressive, which is a new criteria in the DSM. And it kind of combines chronic major disorder with dysthymic disorder. So dysthymic disorder it's often called, of course, persistent depressive disorder or just dysthymia, but it's a chronic type of depression that can last for years if it's untreated. So it's similar to depressive disorder in those terms, but it's very long lasting. So just think of major depressive disorder. Though major depressive disorder can last a long time, but they're saying that persistent dysthymia can last much longer than depressive disorder. So many clients that may have MDD, they can be treated with therapy and medication. However, this new disorder is considered to be long lasting. So that's definitely something to consider. In terms of this disorder, it's also called double depression because it does have milder symptoms, and they may precede the more severe ones seen in major depression disorder. So that's definitely an interesting component. So a lot of people with the major depression disorder are aware that they are, they have a more baseline mood that can sometimes be considered, good or satisfactory, so they can have that level of functioning. But they still have those, of course, chronic symptoms. But those that have dysthymia are, they may never know what a good mood feels like. So that's the determining factor. So with major depressive, they can have a good mood one day, but with dysthymia, it is noted that that good mood may never come. So that's definitely a distinguishing factor in those two. So yeah. Moving on to the next one. And disruptive mood dysregulation disorder. And we talked about this. This is also a new diagnosis. And it was created so that children won't be labeled with MDD, because in my personal opinion, I don't think children have MDD, major depressive disorder. I do feel like it's more along the lines of ADHD and things like that. So I'm so happy that DSM decided to create this new characteristic. So it's a chronic severe irritability and includes temper outbursts beginning from ages 10 and lasts until about 18. So that's where you see that component coming in with children. And like I said before, it was created to reduce diagnosis of depression and bipolar disorder in children. And of course, you have your premenstrual dysphoric disorder, and this is typically centered around depression in terms of menses and menstruation and things like that. So other depressive disorders, and of course, like I mentioned before, substance medicated induced depressive disorder. So a lot of times, whenever substances are introduced, and that's one of the major things that clinicians ask whenever someone is into a psych unit or things like that. They ask if substance use is involved, because it can be a contributing factor for depression, and your changes in your mood. So in order to reduce misdiagnosis, those questions are very important to ask. So we aren't diagnosing someone with MDD who is a substance user that is in a depressive episode or state because of that substance. Of course, and there's also depressive disorders due to another medical condition. So if someone has a chronic illness, that can contribute to depression as well. So it's important to ask if there's any illnesses that can contribute to depression. Biological components. So of course we talked a lot about twin studies, and I think twin studies and genetic studies are very important in terms of diagnoses, in terms of mood disorders. So there's a lot of great information for you guys to touch on in terms of twin studies and when it comes to mood disorders, and if that is genetic and things like that. Let's see if there's anything else I want to talk about in terms of this topic. Like I said, I don't want to spend too much time. So let's talk about treatment. Of course, the main component that is used for MDD and mood disorders is medication. But there's often other forms of therapy and things that can be done in terms of treatments for MDD specifically. So there's electroconvulsive therapy, ECT. This was, if you had me in your history and system classes, I've talked about ECT and how shock is basically shock therapy, and how that's what they used to use back in early times, and they still use it today. They only use it in severe cases, I believe, but it's still scary to think about that they are shocking your brain to get you out of this depressive state or enhance your mood. But if you look it up, it is a widely used form of therapy for mood disorders. But it's definitely something, in my personal opinion, I don't agree with. But that's my personal opinion. You guys have your own, can have your own thoughts on that process. Transcranial magnetic stimulation is similar to ECT, but it's not as invasive. Even with ECT, you have to have someone drive you to the appointment, and they put you under mild sedation, things like that. So that's another factor. There's psychotherapy, and the main one that I typically use for depression and mood disorders is behavioral therapy, and that's cognitive behavior therapy, dialectical behavior therapy, things like that. And those have been paramount in treating mood and depressive disorders in terms of restructuring your cognitive processes and things like that. And there's quite a bit of activities that can be done. But of course, there's other treatments. There's sleep deprivation, phototherapy, and chronotherapy. But some people also do art therapy as well. And that's just another layer of components in terms of treatment. Let's see. So this is probably going to talk one by one about the different levels of treatment and things like that for that. So I don't want to spend too much time because you guys will discuss that. Oh, I do want to talk about, so you guys know what bipolar 1 and bipolar 2 is. So psychothalamic disorder. So this is an interesting one. So it does not involve manic, hypomanic, or major depressive episodes specifically, but it alternates between hypomanic symptoms that don't specifically meet the full criteria for a hypomanic episode. So when you're thinking in terms of bipolar 1 and bipolar 2, they are classified by the length and the severity of depressive symptoms or hypomanic symptoms. So with psychothalamic, they alternate between the two. So it doesn't meet the full criteria in order to be considered bipolar 1 or bipolar 2. So it kind of like, it's like a scale going up and down. And then you have your depressive symptoms, and that section doesn't meet full criteria for major depression either. So that is important to note for this disorder. But of course, 15 to 50% eventually develop bipolar 1 or bipolar 2. But this is just the kind of middle ground between the two, if you would say. So it's definitely an interesting component to a mood disorder. So, of course, when speaking in terms of what causes bipolar disorder, there's genetics, stress, and I talk about this all the time. Stress is a major component for a lot of these mental health disorders and the development of them, whether it's depression, whether it's anxiety, schizophrenia, OCD, things like that. So many things are determined on stress. So I highly, highly, highly encourage you guys to all try to make sure you are monitoring your stress levels and make sure you are getting your needs met in terms of relaxation and things like that. So it's of course norepinephrine and your levels of neurochemistry in terms of how your neurotransmitters in your body processes those levels of stress and hormones and things like that. And of course, high versus low income variation factors can be a contributor. So medication. So the most common medication for bipolar is lithium. But there's so many more. But if you want to learn more about medication, please read a little bit more about that. So we talked a little bit about CBT, so psychosocial treatments. So specifically, psychoeducation is important. So once someone is diagnosed with something, whether that's mood disorder, anxiety, psychoeducation is educating them on the disorder that they have. And I'm not just talking about going to Google and typing in bipolar and reading. You're providing, education on what the illness is, what they can do to help themselves, providing therapy and things like that. And it also helps with improved medication compliance. So if the person knows that they need this medication to feel better, then that is what will motivate them to continue to take the medication and things like that. So CBT addresses problem solving, stress management, communication skills, and relapse prevention. Cognitive therapy plus medication reduces relapse rate. So that's important to note too in terms of mood disorders. So suicide. So suicide is a major component to not just mental health, but everyone's well-being. So specifically when you think of mood disorders and depression severely increases the risk of suicide. Because you are in this melancholy, depressed state, and you feel like you're worthless, your life is meaningless, so it does increase the risk of suicide. Males are more likely to commit suicide, and they use more lethal acts in terms of the use of a gun or jumping off a high building and things like that, or using some form of lethal tactic. And females attempt suicide more, but it's not as lethal. So they're more likely not going to use a gun. They're not going to hang themselves. They are not going to jump off a building. They're more inclined to use pills and things like that. And also age is related to suicide. So there's a lot of correlations in terms of suicide. So there's a couple of factors. So suicide is largely associated with stressful events. So there's 4 categories. There's someone is trying to escape from an intolerable situation. There's aggression towards others. It's an act of sacrifice in relation to some higher values, or it's a game in order to prove yourself to others. So of course there's protective factors in terms of what can someone, if someone's in someone's family is suicidal. There's many protective factors. There's providing, family support, making sure those significant relationships are intact, having a plan for the future, having some form of employment, and ultimately to get some form of treatment, whether that's seeing a therapist once a week or every 2 weeks, whatever that may be, for whatever that looks like for that person. And the person can be suicidal for a short period of time. And sometimes it's longer than that. But there's other factors in terms of prevention and community health mental services that can help with this. And that is it for chapter 11. Let me see if there's anything I want to talk to you about in chapter 12. I talked quite a bit about mood disorder and depression. So here's substance disorders. Let's see. So, let me see. So of course with substance disorders, there's a couple levels or topics of area of discussion. So there's psychoactive, there's addiction, there's tolerance, and withdrawal. And those are the main components that we'll be discussing. So with substance withdrawal, and this is the main area where it's not all substances have, substance specific syndrome. So, and you all know what the withdrawal is considered. So if someone is taking a substance and they stop using the substance, they have symptoms, whether that's sweating, vomiting, things like that. So this, the behavioral, psychological, cognitive changes after stopping a substance can be very severe, and it can entice someone to, of course, relapse. And there's another couple things. So there's casual factors for substance dependence, and dependence is definitely different from withdrawal. So if someone is dependent on a drug, they are needing that drug every day to maintain their level of living their life. And there's a huge controversy over using the disease label, and I hear that a lot, saying substance abuse is a disease, things like that. And the disease model emerged after the Civil War, and it kind of puts like a damper on someone's moral character. So I kind of try to stay away from the disease label, because there's so many other factors that contribute to substance use dependence, and things like that. And we don't want to call it a disease, because of course a disease is a disease. However, substance use and dependence is a problem or issue or something that someone struggles with. So it's definitely different than a disease. And genetics can be a contributing factor to having a substance dependence. But I want to stress that just because someone, say for instance, someone has a family member that uses substances, that does not specifically mean that they will develop a substance disorder. There's other factors that can contribute to that. So yes, they may be predisposed to developing a substance use disorder. However, their environment and how they grow up and their social circle and things like that can contribute to preventing them from going down that path. So I do want to stress that as well. Let's see. Relapse, you guys know about that. So of course there's biological components, and we addressed that in terms of substance use, but there's also psychosocial components. So there's cultural factors, so specific racial and ethnic groups, social and different regions can contribute to, so in comparison to low SES communities or high SES. So if you're in a higher socioeconomic status, specific drugs may be available to you, and you may become addicted to those. If you're in a lower social economics economy situation, then other drugs that are different from the higher SES community may be available to you. So that speaks to that regional social thing, and also racial and ethnic groups as well. Let's see. Of course, there's alcohol-induced disorders. And I will say this, I feel that, of course, there's a lot of talk about how hardcore drugs are dangerous, deadly. But I also believe that alcohol is one of the most deadliest of them all, because it does it as a slow death. And there's studies that show the impact of alcohol. So yes, a lot of people, when people say, "Oh, alcohol's not a drug," it definitely totally is, and it's probably the most deadliest. Let's see. Is there anything else I want to talk to you guys about? I've talked so much. So of course, there's different levels of drugs. There's caffeine-induced disorders, caffeine intoxication. There's cannabis-induced disorders. There's cocaine-induced disorders. Hallucinogenic induced disorders, things like that. So you guys will learn a little bit more about all of these. And specifically in terms of treatment. So treatment for a substance disorder is really difficult. There's a increased risk of relapse and lack of motivation to quit. And you can't, specifically for this one, it's hard to help someone that doesn't want to receive help, right? So my dad always used to say, you can lead a horse to water, but you can't make him drink. And that is definitely the issue with this case. There's a lot of times that, the person has to be willing to receive treatment and want to stop and want to get help in order for them to have the full motivation to quit. And that increases their risk or their successfulness in avoiding a substance. So there's a high dropout rate, and the detoxification process is very hard. So yeah. So of course there's aversion therapies, smoking cessation programs, things like that can help. But ultimately, it's up to the person to be willing and ready to stop using the drug. So there's, of course, treatments. There's skills trainings. There's peer support. There's therapy on substance use and coping skills. There's Alcoholics Anonymous. There's Narcotics Anonymous. Motivational interviewing, contingency management, things like that. Relapse prevention. So most commonly, alcohol relapse occurs in three situations: interpersonal conflicts, negative emotional states, and social pressures. So those are some of the, I guess, components to prevention. Of course, CBT is often used. One interesting one is gambling disorder. So this is in substance use category. So gambling is definitely a different form of addiction. It's, of course, without a substance. So, and there's a quite gender difference in terms of gambling. Comorbidity, it can be tied in with major depressive and substance use. So the causal factors, of course, is it does run in families. It has a Freudian view, kind of a behavioral perspective. So it's along the lines of compulsive disorder, if you will say, and things like that. So of course, and a lot of times people don't know the person has a problem. and it's very inconsistent for medication. It's hard to treat, number one. So you'll have cognitive behavior interventions and things like that. However, it's still definitely something, because someone can be playing video games on their phone, and that can still be causing their addiction to run rampant. Even if they're not going to casinos and things like that, they can still be on their phone, spending up all their money. So it's so easily accessed that it's definitely hard to treat. But yeah. So yeah, that's all I have for you guys. If you have any questions, comments, concerns, please feel free to reach out to me. And I hope you'll have a great week, and I will talk to you soon.